Good morning, everyone. It's a pleasure to be here on a wonderful Sunday morning to share some insights about precision in surgery. It's a very different subject, which normally we don't discuss in conferences, we don't discuss ever in our education. It is something that we never consciously think about. Of course, unconsciously, it's always there within us, all of us. We all want to be precise surgeons. But let us consciously think about what is precision in surgery. And that's why I selected this subject, which is something very dear to my heart. So let's start with what is precision. Let us define precision. So precision refers to the quality of being exact, consistent, and reproducible in measurements, calculations, or our actions. As surgeons, we perform a lot of, calculating the risk. We assess the risk. We, take decisions. We perform our surgeries. We read CT scans. We identify the stage of the disease. And precision refers to being exact or consistent in all these propositions. High precision means low variability between outcomes. So we need to be consistent in our repeated actions. So to summarize the key aspects of precision, one is consistency. We have to be consistently good. There is, the margin of error in our profession is very little, for which the patients pay a very heavy price. And that's why whatever we do, we have to be consistent and we have to give attention to a lot of details. Today, we have so many variables, factors with us, patient's age, comorbidities, patient's condition, their relatives, their social factors, medical conditions, local factors, disease factors, recurrences, high-risk factors, a lot of details we have to consider. In malignancy, we have to consider the staging, and a lot of things we have to consider. And I also want to say that precision is not equivalent to accuracy. We generally feel that precision means we have to be accurate. But precision is independent of accuracy. A measurement, for example, can be highly precise. But if the accurate value, it is far away from the accurate value, then it does not give the accuracy. So we also feel that precision means perfection. But perfection is also very different from precision. Let us see what is the difference between precision and perfection. So precision is a very objective tool. You can measure it. It is a measurable accuracy for the details which can be consistent. Whereas perfection is very subjective. It's a very idealized state. Everybody wants to be perfect, but what is perfection? Nobody knows. It's more like an ever elusive goal. And that's why it is a flawed concept, because the medicine that we practice is not a perfect science. There are so many variables and some of them are beyond our control. Precision is based on consistency and reproducibility, whereas perfection is based on our own personal standards. Everybody has their own standards of perfection and they keep moving, they keep shifting. Today, what is perfection for us, tomorrow will be different. Precision focuses on doing the right things in the right moment. So that is precision. Perfection is more of an end stage. It's a goal-oriented thing, sometimes which is not defined properly, and often it is unattainable because it is a very perfect goal and there is probably no perfection in this world. Precision is driven by very careful execution and sound judgment, good clinical decisions, whereas perfection is often driven by fear of error or criticism. Precision enables progress, learning, and refinement, whereas perfection can lead to paralysis and indecision because we always try to emulate something that is not attainable. So precision clinically improves safety and outcomes, whereas perfection rarely translates into better outcomes. So in short, we can say that precision is about getting the details right, whereas perfection is about doing everything without error, which is not possible in our scenario. Surgery demands precision, not perfection. And it also demands repeated precision because we have to do the same thing again and again with the same precise manner. So to summarize, precision is not perfection. Precision is more objective, more reproducible, more consistency. It can be, practiced, whereas perfection is something which is ever elusive goal. So now let us talk about what is precision in surgery. For most of us, we as surgeons, we are more technical people, more technocrats, and that's why for us, doing minimal access surgery, laparoscopy, or robotics is precision. Yes, that is precision, but that is just one part of precision. And it's not just about doing keyhole surgeries or using big technologies like robotics. That alone is not precision in surgery. Precision, in my opinion, is more about greater respect for tissues, greater respect for the disease and its biology, and to understand that biology is sometimes the king, especially in malignancy, the way they behave can be very unpredictable. And a correct decision making approach, how we approach the patient, how we approach the disease, how we give options to our patients, how we select the correct option, and that itself is more of a precision in surgery. Precision matters the most, in my opinion. It matters the most, and that's why I've selected this subject to dwell upon and to make a conscious thinking about what matters to us as surgeons and how much energy focus are we devoting on those very important aspects that we consider are important for us. So in short, to summarize, precision is to select the right patient for the right procedure, and also more importantly when not to operate. So that is this good decision making or wise decision making is one of the parts of precision in surgery. Selecting the correct operation out of all the procedures that are available. For example, simple thing like hernia today, a small ventral hernia, paraumbilical hernia, there'll be probably 10 ways of operating, but which one is the best for this patient? Probably that selecting the correct, planning for a proper execution, getting the team on board, planning it and executing it well without any problems is precision. Doing the surgeries in the correct anatomical planes, displaying the anatomy, whatever structures we are cutting, trying to identify what we are cutting. So this probably is precision, and of course avoiding to cut structures which should not be. Using the right energy source, optimal energy devices for our tissues, different available. There are so many devices available today for us. And right timing of the procedure. For example, pancreatitis. Even if this patient require intervention, what is the correct time for intervention? Determining this is a very important part of precision in surgery. And having the right presence or having the mindfulness in each of these areas is also precision. So precision is getting the results right, and this is what we all want for our patients. We want that they should get the correct results or the good outcomes. That is what our surgeries are today based out of. So just to give you an example, straightforward lap cholecystectomy surgery here. I think it's not playing, but that's okay. Okay, it's playing here. Okay, so a straightforward lap chole surgery done by one surgeon, adhering to the safe principles of lap chole by creating a good posterior window before going to the Callot's triangle, displaying the large posterior window, and then displaying the critical view of safety, and then going down to getting the artery first and then the duct properly using the ICG probably would be a safe way to do a lap cholecystectomy. In contrast, the same surgery, a straightforward lap chole done by another surgeon who does not adhere to the principles of surgery, probably will end up in a major bile duct injury, even in a simple procedure like a lap cholecystectomy. And that's why dissection in different planes and can produce different results. And precision is following the principles of surgery. How precision has evolved over our lifetime. Fortunately, we were some of the surgeons who are here also were trained in the era of open surgery. And then we learned laparoscopy, and then we now are going into the robotic surgery. And now in the future, we'll see artificial intelligence and other areas which will impact in a very big way in surgery. So we know that almost 100 years ago, during the Halstadian era, the surgery was based on the anatomy. It was more of an anatomical surgery. When we were being trained in anatomy, was being displayed, and that is how the surgery was performed. And then came an era where there was standardization, how to do it in the correct way. There were steps described, and the standard procedures were described, and then practice. And then about 30 years ago came an era of evidence-based surgery, how we must practice what is the correct evidence and then practice the surgery. And then came an era of minimally invasive surgery, which we all have adopted and utilized it for the benefit of our patients. And now is the era of doing image guided and data guided surgeries, navigational tools that are available to us surgeons to guide the procedures. And in the future, we'll have AI to guide us in decision making and making surgeries more precise in the future. So precision evolved when surgeons stopped asking, how can I remove it? And started asking, how can I preserve the safe structures? How can I do this procedure well? So this is just a change in the questions that we ask ourselves. So coming to the main subject, in my opinion, there are 5 pillars of precision in surgery. The first pillar is the decision precision. So decision precision means that we have to have a precision in decision making, selecting the correct patient for the operation, selecting the correct operation, selecting the correct approach, because today there are a lot of non-surgical approaches to treatment like endoscopic, interventional, radiologic, lots of others. And finally choosing when not to do anything for the patient or when we can wait. Today with the imaging modalities, yesterday I was in Jaipur in the IHPBA meeting. I was conducting a panel discussion on pancreatic cystic lesions. And a lot of today with so much of MR and CT being done, a lot of pancreatic cysts are identified. We must know how to observe them, which ones to operate, which ones to resect, which ones to wait. So these are all the very important parts of our decision making. The second pillar is the anatomical precision. So seeing something that is not visible apparently, and that we can only understand by doing, being aware of the correct anatomy of that area where we are operating. So to revisit anatomy is a very important because it's fundamental to our surgeons. The third pillar is we use a lot of energy devices. So using the correct energy and using it in the way. And of course, the fourth tool which we all use so often are the technology in precision, the tools like laparoscopy and the robotics that we use for precision. And I would like to stress that robotic surgery is a precision amplifier. It is not a replacement for precision in surgery. And finally, the fifth pillar, which is something which we don't often think of, which we don't often contemplate on, and which is very important, and that is the presence or the awareness in our surgical action, and that is our mindset, how that works. So presence is essentially mindfulness in surgery, how we can be aware during the procedure, not just in surgery, but even in our clinics. So mindfulness in surgery is something that relatively is, a new concept. Not many people are talking about it, but in my opinion, I've been practicing this very consciously for last almost 7-8 years, and I believe that that has helped me a lot. And this started from one of the areas where, in the theater, in very difficult complex situations when you are, stuck and you don't know what to do, being mindful, being calm, I think being in the moment, being aware of the moment, it helps a lot. Mindfulness is surgery is the ability to remain fully present, fully composed, aware, attentive, especially when there are complications and the stakes are high to decision making in the operating room. Mindfulness transforms stress into clarity and complexity into control. It allows us to take the correct decision, allows us to choose the right approach during stressful times. So, mindfulness, fortunately, is a habit which can be cultivated. That is a good news. I mean, it's not that we are born with this mindfulness in surgery. We can cultivate this habit by being aware about it, by by transforming ourselves from knowing to doing to being aware of our own self and practicing awareness during surgery. So let's start with the first pillar, the decision precision, taking the correct decision. And here we already discussed how patient selection is very important. At 80-year-old, sometimes when we see a patient with a small ventral hernia, we'll think whether to do ETAP or an IPOM. But we should think whether we can leave this patient alone, observe this patient, maybe not operate this, see his functional age. Some people are very fit at 80. So age is just a number. We have to see that function and whether they can withstand the procedure, what is their expected life expectancy, and then we have to take the decision, what is the risk of developing the complication. So we need to assess the risk benefit analysis and take the decision. Today, for most borderline resectable cancers, we use the neoadjuvant therapy, which has now become a standard of care in esophagus, in stomach, in most cases of rectum, and it has become a standard of care even for the pancreatic cancer. So these are the tumors which should not go for upfront surgery, because majority of these patients can have local recurrence or systemic recurrence, and to reduce this risk of recurrence, we now practice what is called as a neoadjuvant therapy. Before the surgery, we give them adjuvant treatment, mostly chemotherapy, but even sometimes radiation therapy in some patients. And these are today part of the NCCN and other guidelines and has become standard of care in our clinical practice. So this is the decision precision, which is very important. The other thing is to do function preserving surgery as far as possible. Now preserving rectal surgeries, parenchyma, preserving pancreatic surgeries, enucleations, or things like that, liver surgeries, doing parenchyma preservation or non-anatomical liver resections. So these are some of the function preserving surgeries. Central pancreatectomy, when the tumor is small in the neck, we can preserve the rest of the pancreas and do a central pancreatectomy. So these are some of the areas where we can really use our precision. Using ICG or fluorescence guided surgery before doing all colorectal anastomosis, even in laparoscopic cholecystectomy to prevent bile duct injury, is a correct decision precision. When we were residents, we had teachers who were very heroic, very bold surgeons, and we saw that we create a lot of harm to our patients. Very rarely this heroism in surgery benefits the patient. And that's why today the generation is that surgeons are more rational. They take decisions based on the available criteria. We discuss, counsel our patients, and then arrive at the best decision. So parenchyma preserving pancreatic surgery, we already discussed, are some of the areas where we can use this precision in decision making. The second pillar is the anatomical precision, seeing better than what is visible. And these concepts have come from the embryological tissue planes. When we started doing laparoscopic colorectal surgery about 25 years ago, that is the time we realized that there are such beautiful planes which we were never aware in open surgery, where we can dissect, because these are bloodless planes. And then the TME concept, the mesorectal excision concept, is also the same concept. We know about mesentery of the small bowel. We also know about mesocolon, but there is mesorectum, which needs to be completely removed. And working in these embryological planes gives us much less bleeding, much better tumor outcomes, much less recurrences. So these facial envelopes, total mesorectal excision for the rectum, complete mesocolic excision for the colon, and now we also understand the mesopancreas. When we do Whipples, we try to do the mesopancreas excision, and for esophagus, we also use mesoesophagus, the periesophageal fat planes and the lymph nodes are removed. So we also are aware about the segmental vascular anatomy of the liver that helps us to do segmental liver resections, segmental vascular anatomy of the colon that helps us to take the colon up into the neck, and esophagus that helps us to mobilize the esophagus only a few centimeters because of its segmental supply. Lymphatic mapping has become better with using ICG for sentinel lymph node mapping, and MIS, laparoscopy and robotics helps us to do better delineation of the anatomy because it magnifies the images and gives us much clearer imaging. So these are some nice words which I like from my dear friend Dr. Parveen Bhatia, who often says this: God has created beautiful anatomical planes. The surgeon, it is our responsibility that we should enter these planes and do the dissection in the correct plane. And I add to this by saying that bleeding is often a sign of imprecision. So if we are a surgeon where we encounter a lot of blood loss, definitely we should think that probably our surgery needs to be more precise. Now in an era of minimal invasive surgery, the blood loss has significantly reduced because we need to keep the fields clear. Only then we can see that proper anatomy, and that's why these surgeries today are more anatomical and more clean surgeries in the MIS platform. The third pillar is the energy precision, and today we have a lot of energy devices. Gone are those days when we used to do a lot of cold cutting scissors. Nowadays, mostly hot scissors are used with cautery. Even in robotics, we use hot scissors extensively. And we use cautery, monopolar cautery for most open surgeries. These are also energy devices. Bipolar is an excellent tool for not just for hemostasis, but even for dissection, lymph node dissection. Bipolar is an excellent tool, open surgery, whether it is laparoscopy or even in robotics. We use the double bipolar technique, bipolar in both the hands for doing a lot of dissection. Ultrasonic and harmonics are good techniques. Vessel sealers are also nowadays extensively used, but every energy device has its own place. We should not be indiscriminate using one device everywhere. We generally use more of monopolar. If there is bleeding, bipolar. If we need lymph node dissection, then bipolar. If we need, mesocolon or mesenteric dissection, then ultrasonics. And if we need vessel occlusion, then we need vessel sealers like LigaSure or other sealers. So that is how we have to use the correct energy device. We also need to understand the mechanics, the thermal spread of these events, use these settings at a very minimum low energy, and have a short activation philosophy rather than using long activation modules to reduce the lateral spread and lateral injuries. So clinical relevance, we don't mobilize the pancreatic stump too much while we do the Whipples to reduce the pancreatic ischemia and reduce the risk of postoperative pancreatic fistulas. Indiscriminate use of energy in lap chole can cause bile duct injuries and strictures, and excessive use on the bowel can also cause ischemia and anastomotic leak. We need to be judicious in how we use the energy, and precision is not just where you cut, but how much energy we deliver at that particular area of the tissue that matters the most. The next pillar is the technological precision, and we are all on the technological bandwagon for last 30 years. The tools that extend our surgeon, minimal access surgery in the last 30 years has changed completely the paradigm of surgery. Laparoscopy gives us today the high definition, almost 3 times the magnification, gives us much clearer views, and it also helps us to use ICG, fluorescence, and intraoperative navigation. Robotics gives us a 3-dimensional vision. It uses the wristed instrumentation, and with about a 10x magnification, motion scaling, chemofiltration, and complete control to the surgeon, the vision control, the assistant retraction control, it gives a much better platform for performing surgery. The robotics by itself does not create precision. It amplifies the surgeon's intent, may it be good or bad. And that's why if the surgeon is precise, then robotics will amplify precision. If the surgeon is imprecise, then the robotics will amplify imperfection or imprecision also. The technology does enable precision, but our judgment is much more important to define the precision. And that's why, though the man and the machine both are important, but the man behind the machine is definitely more important. You may recollect the recent, crash in Ahmedabad. People blame the pilots, people blame the machine. We don't know what is the correct reason, but both the things have to be good. The machine has to be good and the man behind the machine. If this both the things are good, then we'll definitely get a good outcome. If one is not proper, then disasters can happen anytime. So to re-emphasize again, what robotics amplifies: one, the visual precision. It gives a fantastic vision. This kind of stable, three-dimensional, magnified anatomy is not available, this kind of vision currently on the laparoscopic platforms. So we can see the microscopic planes, we can see the small vessels, the nerves, the fibers. Just talking about the TAPP, you can actually see the pre-peritoneal plane versus the pre-transversalis plane. This is very clearly seen on the robotics platform. In the laparoscopy, everything appears same. So this is not a guess, but you can actually do the precise dissection wherever you want. Surgeon sees the correct planes, not just tissues. And that's why we can better identify the safe planes. We encounter less bleeding, and there are fewer unintended injuries because of this. So what does robotics do? The second benefit of the robotics is the motion precision. Because of the articulation that is available, the wristed instruments gives us a 7 degrees of freedom. And with this freedom, you can actually, do much more precise surgery. Also, the robotics help us to get the tremors out because there is a digital interface working between the patient and the surgeon. So the tremors are filtered and it gives us a much better precision. And with a stable camera, wherever you want it, you are working very close. That gives a fantastic vision, magnification, and clarity. The other benefit is the motion scaling. 1:10 motion scaling means that a 10 millimeter hand movements is transmitted to a 1 millimeter tissue movements. So with this, large natural hand movements are translated into micro movements at the tissue level. And this motion scaling, and in most of the robotic systems, we can actually decide what kind of scaling we want. A learner surgeon can use a lower scaling. The proficient surgeon can use a higher scaling where he can go a little bit faster. So with this, what is possible, laparoscopy definitely becomes more reproducible robotically. So laparoscopy in some areas, say for example, laparoscopic whipples, it's a very long learning curve. It's such a long learning curve, it doesn't become reproducible for other surgeons. Whereas robotics, a technology, can actually reproduce this. The best example is the prostatectomy. Laparoscopically, it was very difficult to do a prostate cancer surgery. A lot of open surgeons used to struggle, but when robotics came, a lot of surgeons got onto the robotics bandwagon and started doing prostatic cancers. So similarly, robotics can enable surgeons who are not expert laparoscopic surgeons to transit from open surgery to robotic surgery. But some degree of experience in laparoscopy is a must because both laparoscopy and robotics both are minimally invasive platforms, and the concept or the principles of minimal access surgery like pneumoperitoneum, trocar placement, the assistance, and all these remain very similar between the two. The third and the real benefit of robotics, in my opinion, is suturing and reconstruction precision. So it is this area where there is a real benefit of robotics, where the needle angle control, where you want to take the bite, where the bite should come out, what is that bite thickness, where is the exit, and when you get the bite out, there is no trauma to the tissues from the needle entry or exit, the symmetry, the tension control while you're tying the knots, all this is much more precise. Though one can argue that there is no haptic feedback on the robotics platform. There is no touch feedback. You can't feel how much knot you're tying or how much is the trend. But the visual feedback is so good that sometimes you don't need the haptic feedback. Over a period of time, one can adapt to this and become better. Examples relate to pancreaticojejunostomies, esophageal jejunal anastomosis, and low pelvic suturing between colorectal anastomosis. Since we have started doing robotic surgery, we have actually reduced the use of staplers, and we're doing most of the anastomosis hand sewn. So reconstruction is really the place where robot declares its superiority over the laparoscopy. Just to give you an idea, this is a pancreatic jejunostome in a very small duct, and this is an area where laparoscopy can be extremely difficult with a small duct, because you need very precise tissue approximation, not just the fourth layer, but when it comes to the duct to the mucosa anastomosis, the angles have to be perfect. And this is, you can see that how the visual acuity helps us to tie the knots. And the next is the esophageal anastomosis after a total gastrectomy, D2 gastrectomy done robotically. So here also we now always prefer to do hand-sewn anastomosis, because in deep areas, it gives a fantastic stable platform to do the suturing, the angulation that is available. It's almost that you are sitting there and doing the surgery. That is the feel that you got on the console while you perform this anastomosis. So I think this is a real benefit of robotic surgery. We have started doing all hand-sewn anastomosis, which we used to do in the open era. And when laparoscopy came in, we started doing all stapled anastomosis. Now we are coming back to doing all the hand-sewn anastomosis again. This is our own experience over the last 20 months since we acquired this made in India indigenous robot, the SSI Mantra system. We have performed 260 robotic procedures, GI procedures. I'll share with you the breakup. Upper GI, 60 cases, predominantly fundoplications, and out of which we have done quite a few of redo fundoplications, where there is, I believe, there's a real benefit of robotic surgery, because a lot of additions, dissection is needed in redo fundoplications. There is almost always a shortening of the esophagus. We need to correct that. And we have done a few Porsche flaps for very large recurrent paraesophageal hernias, rolling types. We have done Porsche flaps, which is the latest technology. Without using the mesh, we use the posterior rectus sheath as a flap and encircle the esophagus, and then create a buttress on the crura to do this. So it's a very beautiful, this technique has been devised by Dr. Yalini Vigneshwaran from Chicago. And we have used this technique not even in laparoscopy, but even in robotics. HPB, we have done about 87, predominant have been cholecystectomies. We have done quite a lot of acute cholecystitis, pyoceals, perforated gallbladders, gangrenous gallbladders, all difficult varieties. We have done pancreas, 11 surgeries. We have done about 4 Whipples, 3 Frays operations. We have done cystogastostomies, cystojejunostomies, almost everything that, in the pancreas we have done, and it is very comfortable. Colorectals, we have done about 30 cases, different APRs, ARs, low ARs, ultra low ARs, ventral rectopexis, total colectomy with a quadruple docking, which I'm presenting at the SS80 DDW conference next month in the US, and a restorative proctocolectomy for ulcerative colitis. We have done 2 cases of RPC IPA also. Hernias, we have done about 75 cases, out of which inguinals 47, majority have been bilateral hernias. And incisional 28, we have done all types of ETEPs, IPOMs, and TARs. Also TARs, all different varieties, dual docking TARs, bilateral TARs, TARM TARs, ETEP TARs. So almost everything we have tried and done. And we believe that the real benefit of robotics in hernias is basically the suturing at awkward angles, and it is a much better platform for doing this procedure and others. So total number that we have done so far is 260 cases of robotic GI procedures. This was exactly 1 year ago, last February end, when we celebrated our 100 robotic surgeries. CM Bhupendra Bhai had come to felicitate for this function that was done. Dr. Mahesh Bhai Desai, the doyen and the pioneer robotic surgeon of Gujarat, he came as a chief guest for this program. And recently, in the last month, during a conference in Ahmedabad, we released this atlas of robotic GI surgery. It's called the Hargis Atlas. And in this atlas, we have about 75 videos, educational videos, very beautifully, crisply edited by our team. And there are 53 chapters. There's a multiple contributors. The website is roboticgisurgery.com, but a much easier way of Accessing this atlas is the app. It's called the Hargis app. It is available both on Google iStore and Apple iStore, and it's the best way and the most easiest way to access all the GI procedures have been described here. And this we are trying to standardize the procedures, the port placements, the docking, and everything. We are trying to standardize and publish. And last month, just a few days ago, we also created another first telesurgery, robotic surgery. I went to Delhi and operated a patient in Kaizen Hospital. This was a robotic cholecystectomy done with SSI Mantra. Now with SSI Mantra, more than 150 telesurgeries have been performed in India. There are 40 centers which are connected with a very high-speed dedicated fiber optic cable. And through this, now telesurgeries will become much more frequent, where patients don't have to travel, surgeons don't have to travel, and you can actually operate from sitting whenever, wherever. Suppose I'm today here and I have a patient who has acute cholecystitis, wants a surgery, I don't have to rush back. I can go to Dr. Anurag Nema's clinic and I can probably do the procedure from here and operate in Ahmedabad. So this technology is already developed today. It is there with us. We are not talking about the future. We are talking about the present. So this is possible only in India. For your information, this is not available on the Da Vinci platform. It is not there anywhere in the world, not in US or in the Europe, but this technology is only available to us in India. So robotics is a force multiplier for sure. There is no doubt about it. A surgeon who is a very precise surgeon, definitely adopting robotics, he can get exceptional outcomes. But for a surgeon who is in his learning or he is not a precise surgeon, there can be some incremental improvement for sure, because it's a force multiplier. For a surgeon who is not so precise, it will magnify the errors, because it multiplies everything. Whatever goes input, it multiplies, and then you'll get the output. And that is why, since we also have to understand what are the limitations of robotics, what it does not replace. It does not replace sound surgical judgment, because this is the key first to get good outcomes. It does not replace our sound anatomical understanding of the procedure and the tissues, the respect for tissue biology, and the decision making under uncertainty when there are several factors or variables. So robot cannot compensate for poor planes, poor decisions, poor indications, poor our impatience. This cannot be compensated by using technology or tools like a robot. So what is the precision trap? The dark side of robotics, the overconfidence due to comfort. Once you become proficient on the robotics, there's a lot of comfort. You believe that you can do anything, everything in a very short period of time. So this overconfidence can create complications. Excessive dissection, because it appears very easy, tend to do more dissection. So that needs to be avoided. Energy overuse, because the vision is excellent on a robotics platform. Technical mishaps due to haste or malfunction. On the robotics platform, we have to slow down. And when we came from open to laparoscopy, we had to slow down. Now, when we go from laparoscopy to robotics, we have to slow down even more, because this is a very precise platform where our mindset has to be very perfect. So when precision tools meet imprecise intent, the complications can become inevitable, and we need to be aware about this aspect of robotics, which is not discussed ever in conferences. People only show the rosy things about robotic surgery. So robotic surgery gives us a precise platform, but is not a shortcut. It's a badge of superiority. It is not meant for replacement for the experience or the understanding of the disease process, but it is definitely a platform that rewards discipline, surgeons. It's a mirror that reflects the surgeon's philosophy and his approach and his ambitions. Robotics does not make the surgery precise. It makes precision visible, scalable, and repeatable by the surgeon who approaches it in the correct manner. Now we come to the fifth pillar, and the final pillar of precision is what I call as presence. And this is the missing dimension in surgery. We generally don't give too much of importance to this dimension. In the conferences we see, we talk about tools, technologies, anatomy, we talk about decision making now, but we never discuss this aspect which is so vital in surgery. And this I call as presence. So presence is essentially a focused attention, being aware, having a very calm mind, not getting ruffled when there are complications after surgery, when there's a bile leak after cholecystectomy on the second day. We have to remain calm and see what is going to happen. We have to take all the aspects and take a clear judgment. And it's only with a calm mind that we can have a clear judgment. And even in our clinics, we have to practice this presence, awareness, being attentive to what patient is saying. Patients, we give only about 10 minutes to our patients. We have to be very attentive. Don't have to be distracted by phone calls and things like that, other things. We have to give complete devotion. And this presence or attention, more than prescriptions, will strengthen the doctor-patient relationship. Our bonds with our patients will be strengthened when we are completely focused. So I call this the inside out approach. The inside out approach essentially means that if there is inner stillness, only then we will have outer precision. Without that inner calm mind, we cannot become precise surgeons. If we want to do good precise surgery, we have to work within us. And only with this working, we can become more precise. So the focus has to shift from precision outside to presence inside. And this, fortunately, you can ask, how can we develop this? So the good news is, yes, it can be developed. There are several ways we can develop this. One of the most powerful ways is to practice meditation. So a lot of people say meditation is very difficult. We close our eyes and we get a lot of thoughts. It's essentially sitting in silence, being aware of everything, even our thoughts. We can watch our thoughts. We can be aware of our thoughts. We can just sit in silence. Just 10 minutes a day is sufficient to start with. Gradually, yes, if half an hour, 45 minutes we can do, definitely it will help us. This will help us to train our mind to become calm and focused through meditation. And only a calm mind can be trained to remain calm during difficult situations. So presence is not a personality trait. We are not born by this presence, but it's a trainable skill, and we can develop this skill by meditation. We all, a lot of us people go for walks, go to gyms to train our body, but we do little for our mind, which is so much more important for us to take decisions. And this calm mind in today's world, especially the social media and the phone and the distractions, it is even more important to be calm and be in the presence or in that movement. So there is a connection between robotics and inner stillness. And this I discovered only after I went into robotic surgery, that how we want to develop precision outside, but we need to be more still, more calm inside, more slow inside. And this awareness definitely helps us. So this precision, which is guided by presence, definitely will help us to get better outcomes. So technology has become very advanced, and human mind has to match that advancement, and it has to become more refined. We are still not into the era of AI. When AI comes in, which is going to come very quickly, much more faster than you or I can think, AI is going to enter our all these robotic platforms and the decision making algorithms and things which will be very different. You cannot imagine how quickly it is going to come into our theaters, in our clinics, in our algorithms, in our decision making algorithms. So we have to prepare ourselves for this kind of technology. So the meaning of Kaizen is continuous improvement. This continuous improvement is small improvements, not very big improvements, but every case we learn, we implement in the second case, become wiser, we try to improve that in the next case. We plan everything well in advance. Before doing any major complex robotic surgery, we will have a team meeting, we will discuss all the ports, all the planning, each step. what every assistant has to do at which step, how they have to retract. All this is discussed, planned in advance, so that during surgery there is no confusion. Everybody is on the same page. Everybody knows. This kind of debriefing is very, very helpful. And this improvements have to be continuously done over a period of time to get good outcomes. And this is the Japanese philosophy. And this philosophy has told us that you can actually improve the quality. They started it for the products, but here we are using it for our patients and our services as procedures that we do. And this does not require great giant leaps in technology like adopting robotics or things like that. But it definitely, you focus on the systems and processes. For example, for the last 15 or 20 years, whenever I have been doing a laparoscopic Whipples, there will be a big list of each step of laparoscopic Whipple pasted in my theater, and the anesthetist or the runner nurse would put a note of when we start each step and when we end each step, and then we will review that where we are spending more time, and then we will improve in the next case. So this is how we can develop, learn more and more complex procedures and go ahead. And this, if we continue over a long period, which achieves excellence in quality, we can definitely improve our quality of our care and our outcomes. So Kaizen drives continuous improvement in our quality or whatever we do, may it be at workplace, may it be at home, may it be in our spiritual life, our personal life, our social life. These principles are eternal principles, can be applied everywhere, but it is the spirituality which gives us the grounding, it gives us the humility, and it gives us the direction and the purpose in life by giving a meaning or a purpose to what we are doing in life. Last almost 10 years since the high definition cameras came in and the 4K camera systems arrived on the platform, and they said we can give you a millimeter precision. And I always used to ask, why do surgeons need millimeter precision? And that's not the kind of surgeries we do as GI surgeons. We have big tissues, big organs. Why do we really need this kind of millimeter precision? But then I realized that millimeter precision reduces surgical errors and complications because the margin of error is so low, because it gives us, this technologies like robotics gives us crystal clear view of the anatomical structures. We can actually do bloodless dissections in the anatomical planes, precise identification, control of vessels, and preservation of vital structures like ureters, nerves in colorectal surgery, and ability to do hands-on anastomosis like we do in open surgery. And this has helped us. So I believe that precision in surgery today is not a choice or it's not a luxury. It is a necessity for us to embark on these technologies and these platforms and be better and better. So coming to the end and summarizing why precision matters to surgeons. Definitely, I believe that precision is very important. And I've given a very holistic view of precision, not just precision in surgery, but precision as a surgeon, how we need to practice precision in our surgical profession, because we want to give consistently good results to our patients. That's why precision matters to us the most. We also want to do all of our procedures safely and offer the best treatment for our patients. That's why precision matters to surgeons. We want to do safe surgeries without getting into unexpected or unusual complications, and that's why we need precision as surgeons. And if complications are inevitable and they do occur, which quite often they do in our branches, then we want to detect them early. We want to manage them appropriately, correctly, to salvage our patients from disasters. That's why we want precision in our surgeries. We care also for our name and our reputation, and definitely we want to avoid all these medical legal struggles and issues which can happen today. The patient is also very well informed. As we are, he is also living in an era of AI, and he just has to ask one question to a chat GPT to come to us before they are diagnosed, because from the report they know what is the diagnosis, and once they know the report they will ask the question to the chat GPT and come to us. So they are also very well informed today. They ask a lot of questions, technical questions, and we have to be aware how to answer these problems. The near future, definitely AI, as we discussed, is going to be much more active. Today, it is in the labs. A lot of work is being done currently. And yesterday, I was talking to about pancreatic imaging, and I read an article of AI in pancreatic imaging. It's a 58-page article. I couldn't read it the entire one, but the amount of work that is being done is so huge today that very soon you'll have algorithms where you put in all the clinical parameters and the MRI parameters, and if you have a biopsy parameters, and AI will give you the diagnosis that this is likely to be a microcystic or a mucinous cystic neoplasm of the pancreas, and this is what you need to do, whether you want to operate or you want to resect. That it is going to tell us. So it's very rapidly developing, and it is going to give us a much more precise and personalized treatment very sooner than what probably we expect. So precise surgeons who interact with patients with presence are, in my opinion, safe surgeons. This should be our endeavor when we interact with our patients. Precision and presence should be our guiding forces when we interact with our patients. With this, I come to the end of the presentation, and I always would pray in gratitude for all that I have been given, a lovely family who supports me, a lovely profession where I can take care of my patients, a lovely team that helps me to achieve whatever I want or desire to achieve, and patients who have so much of trust come to us. And of course, Almighty has given us more than what we deserve. So, this is the prayer that I would like to give as a gratitude, that let precision guide our hands, let presence guide our hearts, and let gratitude become our prayer. Thank you very much.